So if any of you guys do want to, you can always go back and re-review any of these unknown sessions or lectures that we have posted on our Derm Path on Demand sort of site here. So I had a lot of guys actually that come up and just sort of randomly told me over the last couple, 3 years that, especially during COVID, that they really got a lot out of the lectures and that it helped them pass the board. So feel free to go in there and use this information and learn as much as you can. I'm sure you guys are going to do great. Okay, so anybody want to get this one started off?
Good morning. I can do this one.
Okay, good.
So this looks like either an excision, maybe an enucleation. And the lesion looks neoplastic to me.
Good.
It looks pretty well circumscribed, so I would say that it's benign.
Good, excellent. Is
And
there
then,
any exception to that rule, by the way? Just now that we're kind of in the end of the year, we should know all the little minutiae at this point, right?
yes, I'm sure there's exception.
Well, something looks benign at low magnification. It looks like a round nodule that's kind of looks symmetrical. Always think of a metastasis, because sometimes those can look benign at low power. Just keep it, you know, have a little sort of red flag that's sort of flashing in the background. Say this is almost certainly to be benign, but just remember that occasionally, like nodular metastasis of a neoplasm can give you an architecture that looks benign, but it's really malignant. So, but you're right. This is going to be benign. So what's the next step?
So looking at the cells themselves, there's a nodule on the dermis or subcutis, and when I was looking at this, it looked like they're both epithelial cells and non-epithelial cells.
Yeah, good. So mostly epithelial. Excellent. I agree with you. And let's go to higher magnification. So could you tell about the type of epithelium when you looked at it?
It looked more like ductal.
There is some ductal differentiation. So now this is ductal. What's this? Is this duct?
No.
No. These describe the cells. You know, they're small, they're round, they're cuboidal, and if you kind of look carefully at them, you can see that some of them, you know, are kind of just little round basophilic cells. They're not as darkly basophilic, say, as a lymphocyte, for example, and others kind of have a little slightly clear staining cytoplasm. So, what type of differentiation tends to give you that pattern in a primary cutaneous skin benign neoplasm?
Are these like basaloid, like spindle cells?
Well, that's spindle. Notice how they're round.
Okay.
Just think in terms of like, okay, so what kind of cell, what kind of normal structure in the skin gives you small, round, homogeneous basophilic cells, but not super darkly basophilic, like say a lymphocyte or like say a stem cell of the outer part of a sebaceous gland, you know, something like that. What other parts of the skin appendages can give you these sort of round cells admixed with cells that have a little slightly clear staining cytoplasm, and they have ductal differentiation also.
Like epithelioid cells?
Well, it's epithelial. It is epithelial. So let's think of the types of epithelium that we have in our skin.
Okay.
We've got epithelium, you know, basaloid, then we've got follicle, we've got sweat gland, we've got apocrine and eccrine. So which of those types of structures is this maybe recapitulating?
Maybe follicular?
That's one. So like in the outer root sheath of a hair follicle, you can get like, you know, basophilic small blue cells plus clear staining cells that have a lot of glycogen in them. And what's another adnexal structure in the skin where you can get these same sort of types of cells like this?
Sweat?
Yeah, sweat gland. And which sweat gland would you like choose more than one over the other? Would you choose apocrine or eccrine more likely?
I thought I saw areas here that reminded me of apocrine.
Okay, it was a good crack at it, but well, actually, if you think about the small, but like if you think of the bottom of a sweat gland, the coil where the cells are actually undergoing a pretty high rapid metabolism. They've got that glycogen in there because they're reabsorbing the ions from your sweat, because as you know, sweat is hypotonic, but when it actually first is secreted in your body, it's actually isotonic, and so it reabsorbs all those sodium and potassium ions, so you don't get fluid electrolyte imbalance when you sweat. So it needs the glycogen in the cells. So these are recapitulating the small cellular structure at the bottom of an eccrine sweat gland. Okay. And then they ducts at the top. And then notice you don't really have any apocrine differentiation. There are no snouting or anything like that. So basically, this is probably eccrine differentiation. So when you see ducts plus small round cells that look kind of they're cuboidal, and they have some that are sort of basophilic and others that have a little clear staining cytoplasm, it's probably glycogen. Think eccrine. So just think eccrine. Now you said there's also some cells out here, structures that were not epithelial. Is this what you were talking about there?
Yes.
Yeah, what's going on here?
So it looks like chondroid-like stroma.
Good. So what's the diagnosis?
A chondroid syringoma.
Yeah. Okay. Now you said you knew the diagnosis, syringoma. Okay, right? You knew this answer. So go backwards. If it's chondroid, you saw that part. If it's syringoma, what kind of differentiation is a syringoma?
That part would be the epithelial part.
Yeah, but what part of the epithelium?
The sweat glands.
Yeah, it's a sweat glands, eccrine sweat unit. So that's thought to be eccrine differentiation. So if it's chondroid syringoma, we say, so this is the eccrine syringoma part of it, if you will. Okay. So yeah, this is and the other name for that is mixed tumor of the skin. Okay. And sometimes, as you can see here, the vast majority of it is the solid eccrine part of it. And in some cases, you'll see the majority of it will be the chondroid part of it. So it kind of varies. Sometimes you get massive parts of it that are the epithelial part of it. Sometimes you get mostly it's the chondroid part of it. Sometimes you just get a lot of mucin with only a little bit of the chondroid differentiation. So it sort of takes a while for that mucin to actually turn into cartilage. That doesn't happen sort of overnight. So, and then there's one other sort of, I don't think the board is going to ask you this, but just in case, what is another part of the body where you see a tumor that looks exactly like this, but it's not in the skin? And what's it called?
The salivary gland, and that could be called a pleomorphic adenoma.
Good, excellent. So again, you get these same kind of cells that can actually be recapitulating minor salivary glands, or even larger salivary glands in some cases. They can occur in the parotid. And yeah, those are called pleomorphic adenomas. They actually will get this lesion, not as much, but the pleomorphic adenoma lesions do get these myoepithelial cells at the periphery of these. So you can actually see that in a cutaneous chondroid syringoma also, but it's more commonly stained for in the pleomorphic adenomas, and you'd stain using smooth muscle actin stain for that. And I'm not sure. I guess those myoepithelial cells may be there to kind of help the salivary gland push out their secretion into the mouth when you're like eating or whatever, the saliva that gets formed there. Okay, very good.
Thank you.
Excellent. Okay, so let's turn this one over on its side here and take a look at it. All right. Different animal here, right?
I can take this one.
Good. I'm not going to let you go to any power higher than this for at least a couple of minutes.
Well, I think from low power, it's obviously a punch. I think the epidermis from this power looks okay. I don't really see anything remarkable about it.
Good.
It looks
Totally.
like, oh, sorry, go ahead.
No, I'm just agreeing with you. You're right on target, on point.
So I would say this probably, at least at this power, fits in the category of superficial and deep perivascular inflammation without epidermal involvement.
They say deep. Maybe a little bit here. I don't disagree with that. Certainly nothing down here, right? Majority of it's kind of up in this area.
Right.
Okay, good. All right, so good. So superficial, maybe mid. So I don't disagree with that. And what do you see at this power. Turn your brain off and just be, just observe and tell me, like narrate what you're seeing in this area.
Like maybe like a lichenoid kind of pattern.
But as lichenoid would obscure the dermal junction, right? So that's going to involve the epidermis. We said it was uninvolved. So it can't be lichenoid because that is involving the epidermis, right? And you can see there's a little grin zone almost at low power. So it can't be lichenoid. But it's kind of involving the papillary dermis kind of in a fairly sort of diffuse pattern, isn't it? This is pretty well involved, pretty well involved here, pretty well involved here. What do you see from a color perspective?
There's a lot of pink at the top.
It's kind of pinkish, kind of reddish. Yes, very good observation. And it's inflammatory, right?
Right.
Okay. What kind of inflammatory cells do you think we're looking at here? You may not know for sure, but what can you infer is not there?
I mean, when I think of pink, I think of like EOS and.
Okay, good. You think of EOS. I'm going to be betting that there probably are going to be some EOS here. I agree with you. What else do you think of when you see kind of reddish or pink at low magnification?
Like hemorrhagic, like.
Yes, good.
Red
Red cells make things red or pink. So yeah, you're going to see some extravasated erythrocytes here. You may see some eosinophils here. What are we not going to see a lot of here?
I'm not sure.
So what looks jet black at low magnification? That's
Jet black at
low power. And it looks jet black because it's got lots of DNA and nucleic acid, which stains very strongly positive with the hematoxylin, so that it looks dark when you look at it at low magnification.
Neutrophils? Pigment?
Close. Lymphocytes.
Okay.
So remember, just picture in your mind, if you see like a lymphocytic infiltrate, like one of the 5 Ls, you see those dark sort of black little aggregations in the dermis. You don't see that here. So there not gonna be a lot of lymphocytes here. But there may be some neutrophils. So when you see a low magnification, there's some cells here, but they kind of almost look like little, maybe sprinkles of pepper, like we put on our Caesar salad or something. So, there may be some neutrophils in here. So low magnification, we've got some extravasated erythrocytes. We've got some neutrophils, maybe some breakdown products of neutrophils, maybe some EOs. We've got no epidermal involvement. What do you think this might be at low magnification? And it seems to be clustering around the blood vessels mostly. What might this be at low magnification?
I was thinking urticaria.
It's possible it could be urticaria. Do you usually get that many extravasated red cells with urticaria? Which type of urticarial eruption do you get extravasated red cells with?
Like urticarial vasculitis?
Yes. Urticarial vasculitis. So as we go to higher magnification, guess what we may be seeing here? Now what do we see? What's all this stuff?
Like nuclear dust?
Yes, excellent. Nuclear dust. And all these were extravasated red cells. And yes, there are some eosinophils admixed in here also. So what's the diagnosis?
Urticarial vasculitis.
Well, it's early evolving leukocytoclastic vasculitis, which clinically can look urticarial, or it can also look like petechia, or a little early palpable purpuric lesion. So if you see urticarial vasculitis, this is what it looks like. So, this could be that, but this is what you also see just in, early stages of leukocytoclastic vasculitis. So lots of nuclear dust. And you can see a low magnification that these aren't lymphocytes. Hey, these are definitely different cells than lymphocytes. They're not jet black. They're not forming nodular aggregations in the skin. They're not really just clustered around the blood vessels. They're interstitially distributed also. So you can, if you see this pattern at low power, you should at least think about it. And then you go to higher magnification, and then boom, you see it. Now, the board's not going to ask you to distinguish between an early lesion of LCD and urticarial vasculitis. That's not fair, because this could theoretically be urticarial vasculitis. But the vast majority of time, we see patients come in with palpable purpura. The clinicians say, "Oh my God, this is LCD." They take a biopsy, and lo and behold, it looks like this. We would like to see in a fully developed lesion fibrin in the walls of the blood vessel and thrombosis of lumina. We don't see that yet because this lesion is early. This is maybe only within the first, say, 18 to 24 hours of its life. So it hasn't even had a chance to really make a lot of fibrin in the blood vessels and thrombose the blood vessels, et cetera. So it's an early lesion of leukocytoclastic vasculitis. If you did immunofluorescence on this, it might be positive. You might see IgA, you might see complement, you might see fibrin in the blood vessel walls, you can see IgG or IgM. We don't know what we're going to see. And the other thing about this is that we sign this out, and then we get a call from an internist, and they say, "Well, what's the cause of it?" And so if the immunofluorescence doesn't show IgA, maybe it's negative, because in a lot of these cases, even though it's really and truly is vasculitis, the immunofluorescence is still negative. We tell them they need to go back to the drawing board and figure it out for themselves, because it could be lupus, it could be a drug eruption, it could be secondary to an infection, it could be due to a lot of things. So vasculitis is really more of a reaction pattern. It's not really necessarily a diagnosis in and of itself. I mean, it is, leukocytoclastic vasculitis, but then it's up to you to figure out why they have it. Do they have HSP? Do they have some underlying connective tissue disease? Something like that. So good. So the next time you see this, you'll be able to get the diagnosis at low magnification. Okay.
I can take this one.
Okay. Little cute biopsy that's fairly small, right?
Cute little shave.
But this is the kind of thing that you very well could encounter on the board examination.
I hope
It's
so.
This is almost pathognomonic here.
Looks like we have some irregular acanthosis of the epidermis. The reedy ridges look a little jagged. There's one focal
Say
area.
jagged. Tell me what you mean by jagged, because when I hear jagged, that makes me think of a certain disease where the epidermal reedy almost kind of look like spikes in a way, that sort of thing. Is that what you mean, or no?
Kind of, but they're kind of just like pointing in different directions.
Okay. Yeah, I think that they're elongated, they're kind of bulbous in a way, but they're not really like, I don't really say that there would be like a classic sort of interface dermatitis or a diffuse lichenoid infiltrate that sort of wiped out these epidermal reedy over here. Maybe here, not over here. Okay.
There's one focal area of nodular inflammation, making the epidermis in that area a little bit more atrophic.
Good. I totally agree. It's wiped out the epidermal reedy up here completely.
Right.
Good.
And at higher power,
This pattern right here. Just what do you call this sort of pattern?
looks like a ball and clutch.
Good. Ball and claw, ball and clutch. Yeah, absolutely. And what kind of cells are in here?
Looked like mostly lymphocytes and some histiocytes.
If you had to give it a percentage, what percentage lymphs versus what percentage histiocytes?
I would say 70% lymphs and 30% histios.
We possibly get you to convince you maybe the other direction?
Switch it around, more histios than lymphs.
Yeah, because if you look, these are the lymphocytes, right? Remember we talked about those jet black cells at low magnification. So these are the lymphocytes in here. But notice that these pale cells here that are forming the bulk of this little nodular aggregation are the histiocytes. So it's actually, when we talk about histiocytes predominating, what do we say that is a sign of? What do we call that when histiocytes predominate in an inflammatory infiltrate?
Granulomatous inflammation?
Good. Granulomatous. It's granulomatous. And we know there are 5 patterns of granulomatous inflammation also, right?
Yes.
Make you recite those, but make sure you know them for the board examination because they're useful. They help you when you're making a diagnosis. So which type are we looking at right here?
Sarcoidal,
Yes.
maybe?
Yeah, I would agree. It's sarcoidal. And why sarcoidal?
It's like no, there's no surrounding inflammation. It's more of a naked granuloma.
Yeah, I agree. There's a little bit of a lymphocytic infiltrate in there. We always talk about sarcoidal granulomas being sort of naked granulomas, but they often will have a little bit of lymphocytes associated with them. It's like they still have at least one article of clothing still on them. So yeah, this has got some lymphocytes in here too, but I agree. It's kind of forming a small nodular aggregation of histiocytes primarily, mostly histiocytes. So what disease do you know that gives you a small nodular aggregation of histiocytes in the papillary dermis with a ball and claw morphology? Some people even refer to it as a lichenoid granulomatous inflammation because it's sort of forming a little band-like, infiltrate of histiocytes, and it does sort of involve the DE junction here. So what disease gives you this?
I would say Lichen Nitidus.
You would say absolutely correct. So that's right. This is Lichen Nitidus, classic. And you can imagine what this looked like in the patient, right? What do these
Yes,
lesions usually look like?
kind of like little white bumps, mostly on the trunk and in children.
Yeah, they can be in the groin area. Sometimes they're on the genital area. They can kevnerize. They can be linear. It's one of the diseases that can give you kind of linear morphology. Okay, so that's the easy part. So let's say you think at low magnitude, you've gone through this, you're looking at your slide on the exam, and then you look down at the multiple choice questions, and they give you 5 choices, and Lichen Nitidus is one of those. But what else might they have there that you need to say it's definitely not this? They're just trying to fool me. I know that it's not these other choices. So what are some other things that they might put in there that might give you a granulomatous inflammation with some sarcoidal morphology, but it wouldn't give you this pattern?
Something like micropapillar sarcoidosis.
Good. I think they would probably put sarcoid, but that wouldn't be the best choice. So if they wanted to make it a hard question, they would say, which is the best diagnosis? And they might put sarcoid because I can give you a sarcoidal granulomatous inflammation. It can involve the papillary dermis sometimes, but that wouldn't be the most likely. What else?
Striatus.
I'm sorry?
Lichen striatus, maybe?
They could put that. That usually doesn't give you as much granulomatous inflammation, and it would be more of a diffuse interface dermatitis over a broad front. If it gives you histiocytes, they don't usually give you these clusters of histiocytes. So that wouldn't be the best choice either. I agree. What else might they choose? What if they put tuberculosis down there?
Well, that's possible, but there's not a lot of
But it wouldn't be the best answer.
Right.
Best. That usually doesn't give you a sarcoidal like granuloma. It usually gives you more of a caseating granulomatous inflammation. So that wouldn't be the best one. And then if they put some other granulomatous things down there, like, zirconium granuloma or something like that, those can all give you a granulomatous inflammation. But the key to this diagnosis is this pattern that you recognized. So that'd be a hard question if they put that. That'd be like on a scale of 1 to 10, that'd be in the 2 or 3 category. It wouldn't be just an easy one. So I don't know. I doubt that they would do that to you, but just in case they do, you're going to be well prepared for it.
Thank you.
You're welcome. All right, let's give this one a go.
Good morning, I'll take this one. So it looks like we have this punch, and from a lower power, it looks like most of the pathology is kind of around the deeper vessels, kind of in the subcutis.
Good, very, very good, excellent. So were they inflammatory process or neoplastic process of low power?
I'm thinking inflammatory process, especially in that bigger vessel. I see what maybe looks like fibrin, so I'm thinking some type of vasculitis.
Okay, good. You're thinking vasculitis. Now, once we get into the category of vasculitis, we've already had one vasculitis today. If this is vasculitis, how different is this than the other one that we saw? How do you classify vasculitis when you are faced with a patient that's possibly got vasculitis? What's your classification scheme?
So one of the first things you can do is kind of look at the size of the blood vessels involved. So this looks a little bit larger than the early LCV one we saw earlier. So it's more of a medium-sized vasculitis.
Good, very good. I agree. And if you talk to guys like Warren Piet and some of the vasculitis experts, they basically say that in the skin, there are no large blood vessels. So you can't get large blood vessel vasculitis in the skin, but this is certainly a larger blood vessel than those capillaries and venules we saw before. So we're probably dealing with maybe a small artery or possibly a little vein that's down here. So I totally agree with you.
And then, so then another we can classify is kind of looking at the types of inflammatory cells around it.
Good. Very
So I see some neutrophils, some lymphocytes.
Yeah, I see a lot of neutrophils here. There's maybe even an eosinophil here. What if we saw a lot of histiocytes here? It looked granulomatous. What would that make us think of?
Like a granulomatous vasculitis.
Yeah. What are a couple of diseases that give you granulomatous vasculitis?
Like I think like tuberculosis, like erythema induratum.
Usually not granulomatous vasculitis, though. That's usually more of kind of a diffuse pattern with nodular aggregations of cells surrounding pre-existing blood vessels, usually neutrophils, eosinophils, eventually fibroplasia. So that doesn't usually give you granulomatous vasculitis. But there's a couple of entities that can, not too many. So it's when you get a situation where a pattern has got only about 2 or 3 things, that's like you're high-fiving yourself, because there really isn't a long differential you have to work through. But you have to know the ones that do cause it.
I think like there's like the eosinophilic granulomatitis.
Okay, so what's in that family of granulomatosis plus angioma, plus vasculitis? What's that other disease called? The eosinophilic, you get nasal involvement, that sort of thing.
I think it's Wegener's.
Well, Wegener's and Churg-Strauss. Okay, they kind of go together. Wegener's, Churg-Strauss, and then lymphomatoid granulomatosis is another one that can give you like a granulomatous vasculitis, and sometimes temporal arteritis. And then infectious diseases can sometimes give you a granulomatous vasculitis. So those can give you fairly large blood vessels involved as well. So that's it. I mean, there's really not too many. So that's the good news is if you see really bona fide granulomatous vasculitis, where there's vasculitis that's got definitive granulomatous inflammation, you can narrow the diagnosis down pretty quickly in one of those few entities. So that's the good news. Okay, so what's your differential diagnosis for this?
For this one, if it's a medium vessel vasculitis and it's mostly neutrophils, I would think about like Polyarteritis Nodosa.
Okay.
If we were
Now, what's the other when you're dealing with this inflammation that's way down here in the subcutaneous fat? Okay, so these blood vessels run in the septa between the lipocytes, right? So we've hit one with our biopsy. So we did a good job here. We got lucky. We nailed one. Oftentimes you miss these with the punch biopsy, but the dermatologist got it. So what if we looked over here at the fat and there was a lot of fat degeneration, and it was like all necrotic fat, and there's some granulomatous inflammation and suppuration in the fat over here. And we had this fairly medium-sized blood vessel with vasculitis. What would that diagnosis possibly be in that situation?
maybe something like nodular vasculitis then?
Good. Nodular vasculitis, erythema induratum, associated with underlying infectious diseases. We used to think it was purely associated with atypical microbacterial infections or tuberculosis, but it's basically, think of it as a reaction pattern. So patients, in my sort of way I look at that condition is that any infectious disease that can be systemic can give you a vasculitis with secondary paniculitis. Syphilis can do it. The reactional Hansen's disease, vasculitides can do it. Erythema nodosa leprosum, that's basically like erythema induratum or nodular vasculitis. So it's more of a reaction. And sometimes even in certain connective tissue diseases, you can get nodular vasculitis, erythema induratum. So it's sort of a reaction pattern in a way. But notice here, we sort of targeted the blood vessel. Blood vessels involved, inflammation is directly around the blood vessel. It's not spreading into the fat. Now, I don't understand why that happens. Why nodular vasculitis will give you the same pattern, but also destroys the fat and gives you lots of inflammation and draining ulcers. This disease gives you nodules in the skin. So I don't know why that happens, but that does happen. So when you see what looks like a rifle shot with a fairly for the skin at least, a larger blood vessel that's involved, and the inflammation is targeting that. And notice this beautiful fibrin, this is fibrin degeneration of the vascular wall here. It's gorgeous. You don't see that a lot of times like that. You should think of PAN. Now, there's one other entity in the differential diagnosis where it also gives you, just targets the blood vessel. It's not an artery, and it's the inflammation just right around the blood vessel. What's that entity that's in the differential of PAN?
I guess if we're thinking this is a vein, you could think about thrombophlebitis.
Good. Migratory thrombophlebitis or thrombophlebitis. So that can look histologically virtually identical to PAN, but it's a vein instead of like probably an artery like this was. And sometimes we'll actually even do an elastic tissue stain or something to see if there's an internal elastic lamina. I mean, we don't usually do that. Usually the clinical is pretty obvious. I mean, this was PAN in this patient. They knew it fit the clinical. They, was pretty classic. It wasn't just a vein on their calf that was, thrombosed. Okay, great. Very good. All right, let's do this one.
I can get this one. We're looking at a punch.
I think I missed. Let me go back up. I think I need to do this one first. Yeah, let's do this one. I skipped one.
I can take this one, Dr. Cockerell.
Okay, good. Sorry about that.
No worries. It looks like we have a punch here. And pretty much from the outset, the epidermis and the stratum corneum look relatively normal. However, we see infiltration of the dermis and maybe even the subcutaneous tissue with these circular collections of cells
Good.
that are kind of like epithelioid macrophages or histiocytes, as well as some multinucleated giant cells.
Okay, so what's the pattern that we would call this?
Granulomatous.
It is granulomatous. You said nodules, so it's a nodular dermatitis, right?
Mm-hmm.
All nodules diffusely.
Yes.
And then you said quite correctly that they were nodules of histiocytes. Okay, and they say, well, okay, what gives you a nodular dermatitis with no involvement of the epidermis with histiocytes here? What's the most likely diagnosis?
It could be sarcoid.
Yeah, that's the most likely diagnosis by far.
Yes.
Okay, so we just got through having Lichen Nitidus. It's a beautiful, nice contrast between that. So let's say they took a shave biopsy like the Lichen Nitidus case, and they happen to hit this one granuloma. You would not call this Lichen Nitidus because notice it doesn't have the ball and claw-like morphology here. It's involved in the papillary dermis a little bit. It's mostly in the reticular dermis, but notice that it's got a small nodular aggregation of mostly histiocytes with some lymphocytes here. Okay.
Yes.
And it's not involving that little ball and claw. So again, we wouldn't choose sarcoid for that because of this. This is what sarcoid looks like. So if you look down at your multiple choice answers here and they put Lichen Nitidus, you'd reject that. You'd say, no, there's no way Lichen Nitidus would ever give you this pattern. Okay,
Right.
so now,
Mhm.
what if they didn't have sarcoidosis as a choice?
Mm-hmm.
Yeah. You look at this, you say, sarcoid, it's got to be. No way that it could not be. And you look down there and lo and behold, it's not there. What are you going to look for as other possible choices that can give you a sarcoidal granulomatous dermatitis that's not sarcoid?
Leprosy.
Good. Very good. Which type of leprosy?
It could be, so there's two types. There's the lepromatous and the tuberculoid.
Good. And then there's all the stuff between those.
Yeah.
So the cool thing about leprosy, it's almost like a spectrum, it's like a tachometer, basically you go from one pole looks like sarcoid, the other pole looks like a diffuse xanthoma with gazillions of organisms in it. So
Yeah.
which of the two poles would this be migrating?
Tuberculoid.
Yeah, tuberculoid. And it's sort of backwards in your brain a little bit because you say, well, this doesn't look like tuberculosis, it looks like sarcoid. But the tuberculoid form of Hansen's looks like sarcoid. The lepromatous form doesn't have much granulomatous inflammation at all. So basically, and you get the borderline types where you kind of get a mixture of those. Kind of get, borderline tuberculoid is going to look closer to this with maybe some foamy histiocytes. The borderline lepromatous is going to have, quite a few histiocytes with maybe some well-formed granulomas. So it's really the body's reaction to the organism. So yeah, what's against Hansen's in this case?
I guess you would expect a little bit of like to see maybe the globi, the
We
bacteria.
don't see globi in the tuberculoid form. So if this was the tuberculoid form, we wouldn't expect to see that. That's really seen only in the lepromatous form. But there's a couple of clues. One is that because the granulomatous inflammation occurs in the nerves, the granulomas are usually kind of elongated and they tend to follow neurovascular bundles. So here we've got some here just sitting in there on their own without any, they're not really obeying or following any neurovascular bundles at all here. They're just kind of randomly scattered throughout the dermis. So that would militate against it. And if you see an intact nerve, now this may be a smooth muscle bundle, but if you see it actually an intact nerve in tuberculoid Hansen's, this may be a little possibly part of a nerve. There's some blood vessels here. There may be a little nerve twig in here. If you see an intact nerve in tuberculoid Hansen's, it ain't Hansen's because it pretty much wipes out every single nerve twig. So it would be in the differential though. It definitely would be. What else would you look for?
I guess, yeah, for the leprosy, kind of like that orientation, I guess the east to west, is that
Yeah,
kind
but
of,
let's say we don't think it's Hansen's. That's not following neurovascular bundles. There might be a little nerve twig left here. So we don't think it's Hansen's. So we're not gonna choose that one. But sarcoid isn't in our list. So we
Mhm.
have to decide what else can look a lot like sarcoid, but it isn't sarcoid.
It could also be like a foreign body reaction.
Good, very, very good. I would choose that next for me. So which foreign bodies give you a sarcoidal granulomatous inflammatory infiltrate that can simulate sarcoid quite closely?
Silica.
Yes, silica,
Uh-huh.
glass can do it. And not silicone usually. Silicone actually will give you kind of more of a diffuse infiltrate, gives you histiocytes, but they're more, you get multinucleated cells, you get foreign body cells, you get the little tiny bubbles inside the histiocytes. So it doesn't really give you a sarcoidal pattern very frequently. So it wouldn't be that wouldn't be our best choice here. What else? Just a couple more.
Also, I think like cutaneous Crohn's can also look a lot like
Yeah,
that.
good. I'd put that in there. Yeah, I would say that. Usually not, and then when you think of Crohn's, think of the other Crohn's-like disorders. The granulomatous chylitis, Melkerson-Rosenthal. Those diseases all kind of fall into the same pattern. They're sort of analogous to Crohn's. So just think of those as entities that involve the mucous membrane, the mouth, the tongue, the GI tract. They're all related to Crohn's. And they usually don't give you these nice tight granulomas like you see here, these sarcoidal granulomas, but they do give you a sarcoidal granulomas pattern. So that's good.
Mhm.
The last one maybe, what if this came from the face?
Granulomatous rosacea.
Good, superb, excellent. That can give you a sarcoidal granulomatous inflammation as well. Often in granulomatous rosacea, you'll often see some maybe some folliculitis, achondroplasia. You may see some tuberculoid granulomatous inflammation with central caseation degeneration also. So you probably, if you looked at your list and it didn't have sarcoid, rather than panicking, just realize that there are some other entities in here that can look a lot like sarcoid, but they're not sarcoid. Okay, now we'll do this one. Unfortunately, it's got a little.
Yes, I can
See,
get this
yeah.
one. Looks like a punch, a rash. I see superficial and deep perivascular inflammation. There's
very
an
good.
ulcer, like an epidermal ulcer, but I'm not sure if it's like pathological or if it's just
Nah,
artifact.
this is
Artifact.
this is where there was a little something in the tissue that got ripped through and they sectioned it, unfortunately. So that's an artifact. But you're right. It's a superficial and deep infiltrate. Now, is that only involved the dermis here?
No, it also has marked involvement of the sub-Q, which
Good.
looks more lobular than septal to me.
Good. Lobular. Yes, it's very diffuse, isn't it?
Mm-hmm.
Septal, you'll only see the septa involved, maybe a little bit of periseptal involvement. This is mostly lobular paniculitis. The whole lobule's involved. Good.
I
All right, now
don't see
we've seen several inflammatory conditions today at low magnification. We saw the vasculitis, we saw the nodular vasculitis, we just saw the sarcoid. What kind of cells are we looking at here?
I think we have a mix of lymphs and some histiocytes and some plasma cells.
Okay, but what's the majority of the cell here at low magnification?
Lymphocytes, like right around the vessel, but then I think histiocytes as well.
What's the majority of the cell?
Lymphocytes, maybe.
Good.
Okay.
Lymphocytes. So low magnification, and that's the key. Again, I'm not going to expect you to make these diagnoses of low magnification. I want you to work through it systematically, but I do want you to, at least at low magnification, come up with some things that allow you to be more of a sophisticated, high magnification searcher, if you will. You know, there's a difference between some guy that wants to go out and pan for gold and just goes out to any stream and takes a little pan, starts panning for gold, versus somebody that's done some research and, you know, they say, hey, you know, used to be a gold mine just down the way here back in the 1800s. And, you know, who do you think is be more likely to find some gold? So if you can look at low magnification and say, well, you know, these are probably lymphocytes here, and I'm smart enough to know that because they're dark and jet black at low magnification and they're centered around these blood vessels. When I go to higher magnification, I'm only going to be thinking about 5 things instead of 40 things. So some people that don't have an approach, they're going to say, oh, this just looks inflammatory and the epidermis isn't involved, and, you know, they're not going to know what to look for. So it just allows you to be more systematic when you go to higher magnification. So yes, we're going to say this is probably mostly lymphocytic, and we know that how many diseases give you a lymphocytic infiltrate mostly around blood vessels at low magnification? There's not 100. There's only about 7 or 8.
Mm-hmm.
And we have a mnemonic device for those 7 or 8, right? What do we talk about when we see lymphocytic infiltrate at low magnification, superficial and deep?
Like vasculitides, or
what's our mnemonic? Like we have angle, you know, Binglin and angle and all that stuff for painful tumors. What do we think of when we talk about lymphocytic infiltrates surrounding blood vessels? What are the 5 or 6 things that cause that?
I'm not sure about the mnemonic, but
5 L's, you've heard of that? Or the 6
No.
L's, 7 L's, you haven't heard of that?
No, I would love to learn.
Okay, well, we gotta get you guys up to speed on that. I know that some of your senior residents have heard that. Somebody want to help her out? What are the L's that give you lymphocytic infiltrates in the skin primarily? You guys know this, come on. What's the diagnosis here?
So here I thought, looking at the combo of the lobular paniculitis and the medial vessel vasculitis, I actually thought it was not like erythema inveratum.
No, it's definitely not. No,
But
it's not. This has got fibrin degeneration of the lipocytes with lymphocytes and plasma cells, like you said in here, it's diffuse lobular involvement. What's the most likely diagnosis of this?
can it be erythema chronica migrans?
No.
Okay.
But that's one of the lymphocytic infiltrates that we think about.
I can help out with the 5 L's, Dr. Cockerell.
Yeah, spit them out for us real quick.
It's lupus erythematosus.
Yes. So what's the diagnosis here, by the way?
I think it's lupus paniculitis. Plus
Yes, lupus profundus. You're right. Plus up here is the lymphocytic infiltrate overlying that. So if we didn't have this, this would be tumid LE probably, right? That's one of the L's. Lupus is one. What are some others?
PMLE, but it wouldn't go this
PMLE, light, lupus, light. What else?
Lymphocytoma cutis.
Good. Lymphocytoma cutis. What else?
Jessner's.
Jessner's lymphocytic infiltrate, which is probably either tumid LE or PMLE. It's probably not really a disease per se. What else?
Lymphoma cutis, and then
Yes. Yes,
Yeah.
sometimes lymphoma or leukemia, CLL can do it. There's a couple others that get a little bit more obscure. She said erythema chronica migrans. What's that? Also, the disease that causes that?
Lyme.
Lyme. That's an L. So you think of Lyme disease, think of the Starry syndrome, think of other superficial gyrate erythemas. Those can give you lymphocytic infiltrates. So that's why it's good to have that mnemonic. So when you look at low magnification, say, this is one of the 5, 6, however many L's you want to make it, but they all kind of start with L. And then you say, well, if there's mucin in here, and there is, then it's probably Tumor LE. Obviously here we've got underlying lupus paniculitis. So this is a classic, beautiful example. And you're right, there is some vasculitis probably of this large blood vessel, but this is secondary vasculitis. This isn't targeting the blood vessel itself. It just happens to be kind of involved in the inflammation that the lupus is causing here. This isn't the typical vasculitis of lupus. The vasculitis of lupus is like that earlier case we had. It's usually a leukocytoclastic vasculitis. So here we've got a beautiful example of the tumid form of lupus erythematosus with underlying example of lupus profundus. And 60% of patients or more with LE profundus have systemic LE. So if you get a patient with this, you need to work them up to make sure they don't have SLE. So remember that mnemonic. So now you know, you'll never forget it as long as you live now, right? So that's very, very helpful when you're looking at these lymphocytic infiltrates. So that's how we do it. I mean, when I see one of these under the microscope, I'm doing the same thing I'm teaching you guys. I'm looking to see, well, is there mucin? Is there papillodermal edema? Are there plasma cells? And maybe it makes me think of the possibility of Lyme disease or possibly Louis, which can give you a lymphocytic infiltrate with plasma cells and some histiocytes also. So that's another L if you want to like expand the list. So anyway, a nice example of that and a good teaching case. And this is one that you definitely are going to encounter lupus on the boards. So you may as well know everything there is to know about it. And you're probably going to encounter a biopsy of lupus on the boards. They might show you a DLE with interface change, follicular plugging, et cetera. They might show you this. So you're going to get this. So you may as well just, some things probably aren't going to get, some esoteric tumor, but you are going to get this. So you may as well just go ahead and be prepared for it. Okay, this is kind of cutesy here. And this is one the boards like to ask this kind of stuff too. Especially if you get somebody that's on the board. It probably, if you want to know what kind of questions they're going to ask, Google the people that are sitting on the board, because they're the ones that are making up the exam, and they have interests that they like to test. So if you get somebody that's like Dr. Yancey, for example, well, he's going to submit some questions about immunobullous disease. If you got somebody like Dr. Elston, he's going to submit some stuff about infectious diseases because he loves those. If you get somebody that's a genetics expert, they're going to ask some stuff about genetics. Pediatric dermatologists like Dr. Paller. So you can kind of predict what kind of questions you may actually be getting on the exam. So let's take a look at this one.
I can take this one, Dr. Cockerell.
Good.
So just from like a low power view, there seems to be kind of like a neoplasm with like some vascular proliferation. It looks like there's a little bit of like a mixed kind of inflammatory infiltrate, and I think some calcium deposits around those areas.
Okay, good. So what kind of neoplasm do you think you're dealing with here?
So kind of like just architecturally, I would think of kind of like pyogenic granuloma with like the epidermal collarette, the mixed infiltrate, and then like kind of lobular spaces.
You're certainly right about that. I mean, there's definitely some granulation tissue here. What kind of cells are we looking at here?
So kind of like a mix of like lymphocytes, neutrophils.
Yeah, on a scale of 1 to 10, how many neutrophils versus lymphocytes and other cells do you see there?
I would say, there's a good amount of neutrophils in there, maybe like
about 95+%. Yeah, I agree. A lot of them. And so we think neoplasm still, and you can change your mind at any point too, by the way.
So there are of course things that can like mimic like PG. You always want to rule out like bacillary angiomatosis.
Okay. But what's this thing here? It's kind of like an elephant in the room, isn't it? What's kind of
Yeah, it
seen-
is. You know, still trying to wonder what it was. I mean, it kind of has like the kind of purplish, dark purple appearance of like calcium.
Yeah, okay. So calcium is one item in the differential. What else gives you purplish color in the skin? So you actually sometimes have to, you think, well, what's the difference with diagnosis of a neoplasm? You have to sort of think, what's the difference with diagnosis of color changes in the skin? Like we talked about clear earlier in the eccrine lesion, that's glycogen. So here we've got purple, and you're saying, well, it's calcium. Is it possible it's not calcium?
Yeah, it could be kind of like an infectious agent. I
Okay,
think
what's
like
an infectious agent?
Botryomycosis can maybe look like this.
Okay, so what's staining in botryomycosis?
Actually, not really sure.
What is botryomycosis? What does it mean? What's the actual disease consist of?
Let's see.
Funny name. Botryo, I think maybe grape or something like that in Greek or something like that. I'm not
Yeah,
100%.
it's just like a chronic, like suppurative like infection.
Yeah, it's a chronic bacterial infection. And what bacteria cause botryomycosis?
Usually like staph, Pseudomonas.
Yeah, it's gram-positive cocci. It's usually staph. I think strep maybe in some cases, but it's usually chronic staph, and it's usually an immunocompromised patient. Usually, so instead of the bacteria causing something like cellulitis or an abscess, they actually start forming colonies, and they get these little grains, and they're grains of gram-positive cocci that you can see when you look at it. So if something's gram-positive, what is that going to look like when you stain it?
Purple.
Purple. Good. Now, are these gram-positive cocci here?
It's kind of hard to say. I mean,
they don't really look like cocci, do they?
No.
Diffuse, maybe filamentous bacteria. Maybe there's something filamentous here in a way. It looks kind of diffuse, and we're not really sure what the morphology is here, but here they may be forming little filaments. And at the periphery, it's got this pink material that's a protein that's kind of around this thing. So this, you know what this structure is called?
I do not.
It's a grain. It's a grain. So when you see grains formed in the skin, they're usually due to bacteria or some other kind of organism. And you can get grains in botryomycosis. What are a few other conditions where you can get grains in the skin caused by infectious agents? I would phone up on this because they may well ask you this.
Yeah, let's see. Eumycetoma.
Yes, fungi, fungal grains. What's a couple of others? We know we've got gram-positive coccal bacteria. Now we've got fungi with like a eumycotic grain in the skin. Those are often dermatinaceous organisms, like Pseudoalscheria boydii or Cladosporium nickii, Madura foot, those kind of things, those kind of grains. And then we've got a couple other grains. There's really only two others you need to know.
There's also like actinomycetoma, like with the sulfur kind of grains.
Actinomycosis, which are also probably filamentous gram-positive rods. Okay, they're not really fungus. They're called actinomycosis. It is a bacteria, we think. And there's one final one.
Trying to see. I'm not really sure what the last one is.
Nocardia.
That's right.
So those are the grains. There's not a zillion of them. There's only about 4 or 5. So then you have to sort of decide, well, which one is it? So if you're going to choose from those, which one of these are you going to choose? But we've already said it's not BotryO because they're not gram-positive. They look like little filaments here. We look at the periphery. We don't have oil immersion to really look at it, but they look like little, almost kind of like a star, if you will. So which one do we favor here. It's also lots of gram-positive purplish color. Almost does look like calcium almost.
Probably actinomycosis.
Good, excellent. So this is actinomycosis. So this is actinomycosis. Beautiful example of that. So if you haven't seen it before, well, now you have. So you can go back and look at it. These are usually seen kind of on the head and neck area, often like in a dental sinus or something like that. And this stuff just starts leaking out onto the skin surface. They're often associated with suppurative inflammatory response, sometimes a suppurative granulomatous reaction. And then all this granulation tissue is just kind of there secondarily. We talk about pyogenic granuloma. Well, originally that meant it was a granuloma associated with pyogenic infection. And so here we've got the granulation tissue with suppuration, and notice that the suppuration is just clustered around these grains here. It's a beautiful example of actinomycosis. So you don't get it much better than this. So if the board's going to show you something, this is the kind of thing they're going to show you. So just make sure you've looked at that and you can recognize it so you won't miss that.
Yep.
No reason to give the boards any more credit than they need. No, don't give them any gimmies. You should get the gimmies. Okay, so last one here, real quick one.
All right, I can do this one. It's Jessica. So we have a punch and not too much going on up higher in the epidermis or the superficial dermis. And then in the deeper dermis, I see like some brown pigmented material. I at first thought this was a hair follicle, but then some of that brown material looked almost like really geometric and had like really prominent walls. So I didn't know if it was like a foreign body.
Okay. Any idea what kind of foreign body it might be?
I was thinking wood splinter was what
You're absolutely correct. This is a wood splinter. Good. Wood splinter. Now, let's see if we can make it a little bit more interesting. Okay, so they didn't think that. What do you often see in the associated with wood? Maybe here, mostly it's just the chitinous material of the plant material. But what do you often see in association with splinters that's dark brown like this?
You might see I think you can get fungal infections.
Yeah, yes. And what kind of fungal growth do you often see associated with a splinter?
I think it's like more of the dermatiaceous fungi.
Yes, good. It's dermatiaceous fungus. Most dermatiaceous fungus lives in the soil. It doesn't cause disease in human beings. It can in some cases, especially if someone is immunocompromised, or it can cause like tinea nigra, that sort of thing. And so let's say we saw, I'm not sure we see any here, but let's say we actually saw some dermatiaceous fungal hyphae. What would the diagnosis be in that case? Would you tell the patient that they need to go get placed on amphotericin because they've got a dermatiaceous fungal infection and they may die from it? Or what would you say in that setting?
So I guess if it was like fungal hyphae, I might. So if we're thinking like tinea nigra, then
tinea nigra is going to live way the heck up here in the epidermis,
oh, yeah,
right?
That's true.
So you might say, well, gosh, if this patient really and truly had a dermatiaceous fungal hyphae in the skin, like chromoblastomycosis or pheohyphomycosis, they wouldn't really have a splinter associated with that. But if they had a splinter like this, it's got it's walled off with granulomous inflammation. It looks like it's probably going to go transepidermal elimination, and this one just hadn't done that yet, so they took a biopsy just to get rid of it. Patient probably complaining of a persistent nodule. It wasn't growing or anything like that. But if you saw the hyphae, would you say the patient truly has an infection or no? No. We see that all the time, and it's just basically the hyphae may have already been growing inside the splinter when it got introduced into the patient, because in real world, these hyphae are growing inside plants and the bark of trees and stuff like that all the time. If you were to just take a piece of bark off a tree and look at it in the microscope, you might see hyphal elements in there. And it doesn't mean that if that got introduced into the patient that they're going to actually get an infection from it. Now, if they're immunocompromised, they might. But if it's just a routine sort of a few hyphal elements seen associated with the splinter, that's just considered a coincidental fungal hypoelements associated with the splinter, and the patient doesn't actually have any disease associated with it. So that's probably the most important thing there. But just recognize this is a splinter, it's a foreign body. They could ask you on the board something like this. They might ask you the differential diagnosis of what looks brown and dark like this. They might put in there something like, say, a metallic foreign body. Well, you're right. You can see there's plant material here. They might put melanoma because it's brown or dark. So those are just some things they could put in there to try to fool you. But if you recognize that it's plant material, the cells here, these are the little cells of the plant. And it probably the plant material looked kind of dark. Might have been a rose thorn in a patient that was a gardener. So this is a splinter. Okay, very good. Good luck to you guys who are graduating. Good luck on the boards. Feel free to go in here and go to DermPath on Demand and look at everything else you want to see here. It's all free. You can look at it and study to your heart's content. So good luck with you guys in career. Enjoyed working with you guys, and we will see you guys the second and first years next year.
Thank you.
You're welcome.